Welcome to UCSF Geriatrics and Palliative Care Grand Rounds. My name is Alex Smith, and I'm delighted to introduce our Grand Round speaker for today, Ashwin Kotwal. Ashwin is an assistant professor of medicine in the Division of Geriatrics at UCSF. He is a graduate of Northwestern University and the University of Chicago, where he received his medical and biostatistics training. He then completed internal medicine residency at the Brigham. Yay, go Brigham! Before joining us as faculty for his geriatrics and palliative care 2-year combined fellowship. I believe Ashwin was the first fellow in that program, and is now been a successful and superstar researcher. I recently wrote about Ashwin that if he had a T-shirt that stated his research interests, on the front it would say loneliness, and on the back it would say social isolation, which might be puzzling to people who see him on the street. He is also, unfortunately, a fan of the Phoenix Suns, who the Warriors did not have a chance to destroy in this year's playoffs, unfortunately. We're delighted to welcome Ashwin to give grand rounds with us today, and look forward to hearing what he has to say. Welcome, Ashwin.
Thanks, Alex, for the great intro. And I fear that you may be right that the Warriors would have destroyed the Suns this year, given our showing in the playoffs, which was a little disappointing. But I'm really excited to be here today to present to you all. I remember as a fellow, the first UCSF Division Grand Rounds I came to was Mindy Fain from University of Arizona, which was amazing. And each Grand Rounds, I could see how fulfilling the research in geriatrics was and how fun a community or division was. So thank you for giving me an opportunity to share what we've been up to over the last 3 years while I've been on faculty. So I'm going to share my screen. All right. Okay, and hopefully you all can see that okay. All right, so here are my disclosures. My commercial sources include Humana, where I'm conducting contracted research to study the nonprofit Institute on Aging Friendship Line. I also take research consulting fees from a tech startup, Papa Health. I'm not going to be discussing work relevant to those commercial sources today. I also have recently had or have funding from the NIA and National Palliative Care Research Center, and I'll be presenting related research, but it doesn't represent the views of those funding sources. So before we get into today's topic, I know that on many people's minds are the horrific shootings that happened yesterday in Texas and nearly 2 weeks ago in Buffalo. And so I just wanted to invite you all to take a brief moment of silence to reflect on these events in our country. Thank you. I know that it's a lot to think about, and I encourage you all to translate those reflections and thoughts into actions as much as you possibly can. So with that, let's get into today's topic. So today, my overall goal is to provide an introduction and overview to the concepts of loneliness and social isolation. And we'll also think about a framework for thinking about interventions. So the questions we'll be specifically thinking about are, number one, how are loneliness and social isolation defined and what are their health effects? The second is we'll think about how older adults experience loneliness and isolation during the COVID-19 pandemic. And then third, how we can support older adults experiencing loneliness and isolation. And in this third section, we'll apply a framework for interventions in a clinical setting. So let's first think about these definitions and health effects. And to add a little bit of fun to today's talk, I'm going to be using Poll Everywhere, which UCSF apparently has a membership with, which I just learned a couple days ago. So here are some of the instructions to join. If you want to pull out your phone or go to the website on your computer, pollev.com. I'm so lonely, which kind of sounds like a very sad 90s AOL Instant Messenger chat room. You can also text I'm so lonely once to 22333 to join, or you can use the QR code. So I'll give you a second to log on to that. And while you're logging on, here is our first question. So what is your favorite song about loneliness? So we have a couple of options here. We have Eleanor Rigby by the Beatles, also known as All the Lonely People. We have Lonely by Alvin and the Chipmunks, which was remixed by Akon, which I've had stuck in my head ever since I started this question. Dancing with Myself by Billy Idol, All by Myself by Eric Carmen. And you can also select E if you know a better one. So we'll wait for some of these responses. Let's see. And there may be an issue with Poll Everywhere because I'm not seeing what I typically see. I'm just going to restart. There we go. Okay, perfect. So we see some responses coming through. And we have Eleanor Rigby as the near clear winner, All by Myself as a number 2. And if you selected a different question or a different song, please post that into the chat because I'd love to hear it so we can make some Jerry Powell requests in the future, hopefully. And this picture is of Eleanor Rigby in the UK, where you can actually sit next to her on the bench and make her feel less lonely. Okay, so whether it's the music or media, I think as a loneliness researcher, you start to notice loneliness popping up everywhere. Here's a collection of headlines from actually before the COVID-19 pandemic, where it was described as deadly, an epidemic. Vivek Murthy, actually, our Surgeon General, wrote a book called Together, which detailed how social connection was incredibly valuable to our health. So there was a lot of discussion and recognition, I think, in the public sphere of the importance of loneliness and social isolation to our health. But what I noticed increasingly as I was doing fellowship at UCSF in geriatrics and palliative care was that there was a disconnect. As people were aging or as people were approaching the end of life, social isolation and loneliness were an incredible source of suffering for people. But even though they were prioritizing these concepts in their own lives, as clinicians, we weren't doing a great job of integrating people's social needs into their clinical management. And so this kind of set me on this course to think more about these concepts and how we might address them even in clinical settings. And I think part of the challenge was for clinicians, it was a little bit difficult to pin down what exactly loneliness meant. It was a little bit amorphous to many clinicians, but it turns out these concepts have very specific definitions which can guide both how we conceptualize their health impacts, but also how we think about potential interventions. So loneliness is defined as a subjective feeling of being alone, or the distress that results from discrepancies between ideal and perceived social relationships. Something many of you all in our division probably have heard me say is you can feel lonely in a crowd. So many people have relationships or may even be married and still feel lonely. So it's an incredibly common experience throughout the lifespan. So here's one figure on the left, which shows that loneliness tends to occur throughout the life, peaks in middle age, and can become an increasingly common experience after around age 70. Over 40% of older adults in the US describe feeling lonely at least some of the time. And this is a global phenomenon. In the UK, about 1 in 10 individuals report feeling frequently lonely. And there's a lot of different factors that may contribute to experience of loneliness. I really like this figure from the Optimizing Aging Collaborative at UCSF, which points to both intrinsic as well as extrinsic factors. So intrinsic factors may include your personality, your psychological response to social interactions, certain social group memberships based off of age, income, race. And then there's extrinsic factors, things like your personal circumstances, environmental factors like your neighborhood and neighborhood safety. And then, at the VA, I think a lot about veterans who've experienced PTSD because that can really impact people's ability to socialize over a long period of time. All right, so here is our second question. Again, I think we're having issues with poll everywhere. I'm going to restart so we can get this going again. So the second question is, how do you identify loneliness in a clinical setting? And so our options are, you can ask, are you lonely, even when you're in a crowded room? The second, you can ask a validated scale for people who are really into evidence-based medicine. So things like the UCLA 3-item scale. Some people might wait for their patients to tell you, or you usually don't ask. And then many people can use clinical judgment or other options. All right. All right, so as a clear winner, we're seeing I wait for my patients to tell me. I usually don't ask. And that's super common. So, a small selection of people will ask people directly if they feel lonely or use scales, and then clinical judgment. Great. So, I think this speaks to just how difficult it can be to talk about loneliness sometimes. It's a sensitive and often stigmatized topic. And so many clinicians don't bring it up, and often many patients don't bring it up on their own unless it's a really substantial source of distress. But there are ways of getting at this. So the UCLA 3-item loneliness scale is probably the most commonly used scale in the US. Ask 3 questions. Do you feel left out? Do you feel isolated or like you lack companionship? And you'll notice it doesn't use the word lonely in there, with this idea of trying to avoid that sensitive nature of self-identifying as lonely. And people who answer at least 1 point on the scale are often considered lonely. We've also done some work that was recently published, which suggests that just a simple question, how often have you felt lonely in the last month, can be a really reasonable way of assessing for loneliness, especially during the pandemic when it's become such a common experience. So what are some of loneliness's health effects? One of the most highly cited studies in the medical world was actually published by our very own Drs. Parissinoto, Senzer, and Kovinsky. It was published in JAMA Internal Medicine in 2012. They used our favorite national survey, the Health and Retirement Study, to follow about 1,600 adults over 60 years old for about 6 years. They were asked if they were lonely based off of the UCLA loneliness scale, and they tracked certain outcomes, including death and a decline in function. So what did they find? So the first was loneliness was incredibly common. About 43% of individuals in this study experienced loneliness at least some of the time. And the prevalence findings challenged some of our assumptions. Among people who are married, nearly 2/3 of individuals reported experiencing loneliness. And in contrast, for individuals living alone, only about 1/4 of individuals reported loneliness. And when they were followed over time, they were found to have a higher rate of incident ADL disability, so 25% versus 12.5%, and a higher rate of death, 23% versus 14%, And these findings held up even after multivariate analysis. So what were some of the conclusions from this study? Well, loneliness is common. It's an independent predictor of functional decline and death. And this really built on several decades of sociologic literature, but was the first to really bring this into the medical world and help people start paying attention to this. Since then, there have been a lot of studies which show the impact of loneliness on health. So for quality of life, for example, Powell and colleagues from University of Michigan recently published in JAGS a great study which shows that loneliness is deeply intertwined with physical and psychological symptoms like pain, anxiety, depression, fatigue, and the cluster of these symptoms. And work that myself, Mike Steinman, Irena Sensor, and Alex did recently published in JAMA Internal Medicine, we found that loneliness was associated with downstream medication use for many of these symptoms. So things like NSAIDs, antidepressants, anxiolytics and sedatives, opioids, and even polypharmacy, all of which are known to have adverse effects among older adults. So I think taken together, loneliness is thought to have two primary mechanisms by which it impacts health. The first is, by definition, it's emotional distress. And when that's experienced over a long period of time, that can cause a stress response, which disrupts our sleep. It can cause motor function decline and the general wear and tear on our body. And the second mechanism is that it can affect our health behaviors and how we receive medical care, including through these medications. And this is very similar to other psychological conditions. Okay, so how about social isolation? Social isolation refers to a complete or near complete lack of contact with society. It relates to a quantifiable number of relationships. And one example clinical screener that I use is looking back over the last year, who are the people who you talked with most about important things? So that's getting at people's core social network. And when people have a hard time naming anyone, that might mean they're isolated. National studies have consistently found that about 1 in 5 older adults are socially isolated. And here's a question for the audience. How is social isolation associated with health outcomes? So true or false, the association of social isolation with mortality is of similar or higher magnitude as physical inactivity, obesity, and air pollution. All right, and that was kind of a fairly straightforward question. So 100% people saying true, that is the case. So social isolation has been strongly associated with mortality in a number of studies. Here is one of the first studies in 2013 published in the Proceedings of the National Academy of Sciences that found strong associations with mortality. This was replicated in a 2020 study. And Dr. Julianne Holt-Lundstad out of BYU published a meta-analysis that received a lot of press, which showed that social isolation does have a similar or higher magnitude of association with mortality combined to other risk factors, including smoking cigarettes, about half a pack of cigarettes a day, alcohol consumption, physical activity, obesity, and air pollution. And this got a lot of press, including from the Surgeon General in this tweet. There have also been a number of specialties that have become more interested in social isolation as it's affected health outcomes relevant to their field. So here's a great study that was conducted by Jason Falvey out of University of Maryland and Lauren Ferranti out of Yale University, which used the NHATS data to follow nearly 1,000 older adult survivors from the intensive care unit. And they found that each 1 point increase on the social isolation score was associated with a 7% increase in disability count and 14% increase in mortality. And here's the survival curve from their JAMA Internal Medicine paper, which is really impressive. I mean, the 6-point group in particular is quite worrisome in terms of their survivorship and disability. What are some of the mechanisms by which social isolation impacts health? Well, social isolation doesn't bother everyone. In fact, some people prefer to live in isolation or solitude. But I increasingly think of this as a health behavior. People who don't socialize or don't have social connections may miss out on the benefits of socializing. Things like um, uh, being physically active, receiving emotional support, or even cognitive stimulation. And I think in times of crisis, when people are isolated, they can lack key support to get them through that crisis. They may not have financial support, medical or caregiver support. They may not have instrumental support, things like just getting transportation to a scheduled medical visit. And they may lack an emotional buffer to address nuance of depression or anxiety. Okay, so just to recap here, the key point is that loneliness and social isolation are related, but relatively distinct concepts, and they have distinct mechanisms of impact on health. Okay, so how about with serious illness? This has become an increasingly important area of interest for me because I see this a lot in palliative care clinic where individuals experience loneliness and social isolation, and it can have profound impacts on their health. So, I was really inspired to think about loneliness and isolation among seriously older adults from a lot of prior work that has been done in this field. So in particular, Dr. Karen Steinhauser out of Duke University conducted a national survey of bereaved caregivers and seriously ill individuals approaching death to ask them what their priorities were. And what often emerged was social priorities were just as important as other medical factors. So for example, nearly everyone said that having someone who will listen, sharing time with close friends, presence of family, or being able to help others was important for them in the last weeks or months of their life. What I've noticed though is when individuals are coping with serious illness, they have pain, they have new disability, they are experiencing significant cognitive impairment, they have a much harder time coping with loneliness than they might have earlier in their life, where it might just be a motivation to go out and connect with others. And as we talked about just previously, when people are socially isolated, it can impact their quality of life and their ability to get support for needed healthcare. So we conducted a study to just understand the prevalence of loneliness and social isolation in the last years of life among older adults. So there's a lot of information here, so I'll walk you through that. We used the health and retirement study, and we included a cohort of about 3,600 older adults who responded to questions about loneliness and social isolation in the last 4 years of their life. So on the x-axis here is the time of the interview prior to death, broken up in 6-month intervals. And on the y-axis is loneliness, shown in the blue, and isolation, shown in the yellow. So what you can see is that loneliness was incredibly common. In the last 6 months of life, nearly 4 in 5 older adults reported loneliness. That was loneliness at least some of the time. For frequent loneliness, or a score of 4 points or higher on the UCLA scale, about 1 in 5 older adults reported loneliness. So incredibly high rates, nearly double the prevalence in the general population of US older adults. For social isolation, it was an increasingly common experience as people approach the end of life, nearly more than doubling from 16% to 34% in the last 6 months of life. And here's a question for the audience. Loneliness and true or false? Do loneliness and social isolation commonly co-occur? I'm just gonna restart this. Weird that this is happening. There we go. All right, true or false? So about 9 out of 10 people said true, and 10% of people say false. The 10% of people might be Arena and Alex. Yeah, actually, so loneliness and social isolation do not commonly co-occur. In our study, we found only about 5% of our sample had both loneliness and social isolation at the end of life. And that speaks to this phenomenon where it's really separate pathways that are leading people to these social experiences. So there are a lot of different losses that individuals are experiencing at the end of life, which predict loneliness and isolation. Things like a death of spouse, death or loss of relatives and friends, changing living situations, and changing health conditions, including deteriorating physical health, impairments in mobility, impairments in vision and hearing, and just reduced social activity. One factor that I will specifically call out, though, as important was cognitive impairment. So cognitive impairment was highly associated with both social isolation and loneliness at the end of life, with rates increasing from 18 to 26% for people who were socially isolated and 16 to 26% for individuals who are lonely. And so this is a cognitive impairment is a factor that we're exploring further using qualitative interviews. Some of this work being done with Dr. Krista Harrison, as well as using the HRS study to look at whether cognitive impairment and social isolation impact end-of-life healthcare use. Okay, so now that we've defined loneliness and social isolation and their health effects, now let's think about the COVID-19 pandemic and how that may have amplified or affected people's experiences. Okay. All right, so just at the start of the pandemic, we were really concerned that physical distancing restrictions would really amplify this epidemic of loneliness and isolation. Here's a headline from April of 2020 by Paula Spann, which said, just what older people didn't need, more isolation. And so we started to set out to, document what was happening with what we initially thought was going to be a short pandemic, so that we could help older adults recover. So we conducted a study in the San Francisco Bay Area among about 150 older adults recruited from the UCSF Geriatrics Clinic. Thank you to those in the audience who helped us recruit from the Curry Senior Center in the Tenderloin neighborhood, and Covia Senior Services, which is a nonprofit that serves many Bay Area older adults. And we followed them for about 6 months, in the first 6 months of the pandemic. We found that loneliness was common. About 1 in 3 had frequent feelings of loneliness, and over a half of individuals reported worsened loneliness due to the COVID-19 pandemic. Loneliness often clustered with other concerns, including depression, anxiety, worries about COVID, and worries about delayed medical care. When we looked at their ability to connect with others to kind of overcome physical distancing restrictions, we found that telephone communication was by far the most common form of communication. But concerningly, about more than three quarters of individuals had minimal video interaction with their social network, and over 40% of individuals had minimal internet use to connect with others. And individuals who had these challenges using technology to connect with others, they more frequently described unmet needs in terms of finding help with bathing, getting their medications, and in general, just getting help at home. These levels of difficulty using technology persisted for many months through the pandemic and even a year out when we did our follow-up interviews. And so we started to explore, how older adults have used technology to overcome pandemic restrictions. And here are some of the results from qualitative work done by a really fantastic MD PhD anthropology student, Rebecca Newmark, here at UCSF. And she purposefully sampled older adults with a wide range of technology experiences during the pandemic. And she found some interesting theme. So, in general, there was a lot of positivity related to technology, people who are discovering new technologies, including Zoom, people who are increasingly resourceful and finding help in the community, programs like Senior Vitality, San Francisco Village, where people could take free technology classes. But there were also challenges. So there are internal barriers like internalized ageism that many people described. Here's one quote: "I'm so stupid and so out of it that I'm afraid to even take a class. I don't want to get in a position that everybody's saying, wow, look at her. She's so old. She ought to know how to do something." And then, of course, there were external barriers, things like a lack of age-friendly technology. Here is one quote: "I don't have good skills, so I can't play with my photographs. I have difficulty moving around files and folders. I get stuck with passwords. I can spend hours losing and finding passwords." And another question, is virtual interaction enough to address our thirst for human connection? So here's a question for the group that I will restart. Is how often is virtual connection enough for you to fulfill your thirst for human connection? And as we're waiting for answers, I'll just share with you this meme, which is when you finally meet your coworker in person after a year of only Zoom meetings, you're shorter than expected. Unfortunately, that was a response I got a lot at the recent AGS conference. All right, so it's coming up. So, okay, well, fortunately, nobody's saying never. And we have some kind of a mix here. All right. About half of individuals are saying some of the time, a third saying hardly ever, and about 1 in 5 audience members are saying often. So that's great. So clearly, different people have different needs. And when we looked at older adults in a national survey, we kind of found similar things. Virtual connections were often not a substitute for in-person interactions. So what we did was we looked at decreased in-person family contact and decreased in-person friend contact from a 2015 interview to 2020 interview. And we found that when people experienced decreases, they had reduced happiness, increased depression, and increased loneliness. And that was especially the case for friends, where they had really high levels of loneliness when they had decreased contact with their friends. For older adults, when they had increased video calls or other forms of virtual communication, that really just wasn't enough to offset these massive increases in psychological distress. How about for nursing homes? Unfortunately, there's been fairly little research done in nursing home settings. Here's one survey that was conducted by the nonprofit Alterum Group from during the summer of 2020, which found pretty profound levels of loneliness and isolation, perhaps unsurprisingly among nursing home residents. Over 3/4 felt lonelier. Very few individuals had visitors 3 times a week. Most individuals never reported leaving their nursing home, and over half of individuals reported no in-home organized activities. And I think as many people in the audience can attest to, these restrictions and these challenges have persisted as we've experienced each surge in the pandemic, and visitor restrictions have been put in place. If you look at some of these quotes here, they can be really heartbreaking. When I remember presenting to the VA group, I think in 2021, and something that Lisa Dipko from the CLC, who's a social worker, said was that it's not just the residents that are missing out on these social connections. It's really a two-way street. The residents are so critical to the well-being of individuals outside of the nursing home, their family members, their grandchildren. And so it's really been a huge source of suffering, I think, all around. Okay, and what are the current trends during the COVID-19 pandemic? So there's been a lot of data from earlier in the pandemic, very little from incorporating data from 2021. And so we've been partnering with the Northwestern University Pepper Center to examine older adults enrolled in their C3 study. So it's about 670 English and Spanish speaking adults. There's 7 waves of data starting from March 2020 all the way to December of 2021. 2022 has not occurred yet. And we characterized trajectories of loneliness over 18 months using this question: over the past week, how often have you felt alone or lonely because of the coronavirus? So what we found was there are basically 4 different groups that had distinct trajectories during the pandemic. And I'll walk you through each one. The first group that we identified was individuals who've been persistently lonely throughout the pandemic. And that's in the green here, where in nearly all of their interviews, they reported loneliness. The second group, occurring in about 1 in 5, were individuals who were initially extremely lonely, but they seemed to adapt over time, or at least report less loneliness. There are individuals with occasional loneliness, reporting loneliness in about 2 of 6 interviews. And then individuals, about a third of our group, had really no loneliness, very rarely reporting loneliness throughout this study period. When we looked at factors that were associated with an increased risk of persistent loneliness, we found that poverty, so living below the poverty line, living alone, individuals who had minimal use of technology, and individuals with pre-pandemic anxiety and depression were at much higher risk of experiencing persistent loneliness. And I think that just highlights, that we really need to be thinking about who is continuing to suffer from pandemic restrictions and how we can help people recover from what might be long-term effects. Okay, so we've thought about definitions, health effects, and how the pandemic may have amplified these experiences. So now let's turn to how we might support older adults experiencing loneliness and social isolation. So in order to to illustrate a clinical framework to address loneliness and isolation, I'm going to use 3 clinical scenarios that I actually saw in fellowship, which kind of helped me start thinking about this framework. I've altered the names, but many of these clinical scenarios may resonate with your own clinical practice. So the first patient is Margaret. She's a 94-year-old Navy veteran. She's wheelchair bound and has severe macular degeneration. She lives in an assisted living facility, and she's actually visited by her children and family members quite a bit, but when she was told that she couldn't volunteer anymore, she felt profoundly depressed, and she said her life lost all meaning. The second is Bill. He's an 84-year-old with mild cognitive impairment and was recently diagnosed with an advanced metastatic cancer. He doesn't report feeling lonely, but because he has his cat Yip Yip, who he describes as an incredible companion, but he is often missing appointments for his oncology visits, and we had a little bit of trouble reaching him. And then there's John, who's an 89-year-old veteran who was incredibly active in his community until recently, when he fell and broke his hip, and now has had trouble making it to his local coffee shop, and has also felt quite isolated, being relegated to his home. So, each of these individuals has a social experience that's greatly impacting their well-being. Margaret is not isolated. She's actually surrounded by family and friends, but when she was told she couldn't volunteer, it caused profound loneliness, a loss of sense of belonging in her community, and existential distress. For Bill, he's not bothered by being away from family or friends at all because he has his cat Yip Yip, but he's completely isolated. So he's prone to missing appointments, and he doesn't have a designated power of attorney. And then there's John, who kind of is in the middle here, who is experiencing both isolation because he's newly homebound after his hip fracture, and is quite lonely because he isn't able to participate in social activities that he previously enjoyed. So how might we think about medical management here? Well, I think it's helpful to think about a geriatrics classic here, so falls. Before I did geriatrics fellowship, if I saw an older adult in the hospital who had experienced a fall, I might, order a physical therapy consult, do a cardiac and neurologic workup, and if there was nothing too concerning, I would send them home. No big deal, right? If we were in person, I would hope that you would start booing me and throw me out of the building, because of course we know that this is completely inadequate. In reality, there's a geriatrics approach that requires a multi-component interdisciplinary interventions, all of which are backed by evidence. Similarly, I think prior to the pandemic, when we saw poor social support, we'd often defer as clinicians to other colleagues in nursing, physical therapy, or social work to address these needs. But I think in reality, there's a lot we can do as clinicians, part of an interdisciplinary team, using an individualized approach to really address people's needs. So overall, this is a huge area of research where the National Academy of Sciences released a report in February of 2020, very presciently, suggesting that healthcare systems really need to take an active role in addressing social isolation and loneliness in older adults. And they highlighted 5 domains where people can really make progress. So developing a more robust evidence base, translating current research into healthcare practice, improving awareness, strengthening ongoing education, and strengthening ties between the healthcare system and community organizations. So this has really been an area where we've been focusing on a lot, all of these domains to really make progress in this space. So let's think through a clinical approach then, because I think it's important that as we're waiting for the evidence base to catch up in terms of interventions, that we have a framework to address this because of the suffering that it causes for many of the individuals we see in our clinic. So the first step is identifying loneliness and social isolation. We can do a lot of these concepts go unrecognized in clinic because we never ask. It's sometimes uncomfortable, there's stigma, it's a sensitive topic. But there are a lot of questionnaires that are out there that can get at this in a reasonable way, especially during the pandemic when this has become a much more common experience. I often use the UCLA 3-item questionnaire, and social isolation. There are several social network indices that are quite quick to administer. These have actually been built into Epic, so through the Frailty Navigator, so hopefully to reduce some of the barriers to addressing this. I think routine assessments of these social markers can spur clinical research. I was just recently seeing an article done by Dr. Jen Wai's group on transplant hepatology, which found where she's actually started asking these questions in her large studies and found that loneliness is super common among transplant recipients or people waiting on the transplant list. So I think identifying this is the first step to developing interventions. The second is we can think about clinical interventions in 3 different ways. The first is direct interventions, which directly try to enhance people's social connections, or at least enhance people's perceptions of their social needs. There's a number of different interventions, but I'm actually curious from the group if there are particular interventions that people have found to address loneliness or social isolation. I'm restarting one more time. So people can actually type in answers here. It can just be a few words if you'd like to. And you can also upvote the interventions that you see. So we can give it a couple of minutes here. Volunteer work. Robot dogs, awesome. Some people prefer the robot cats though, which can be, a little bit more intrusive in certain situations, but also, nice companions, and a Zoom companion in particular. Zoom meetings for cookouts with families, adult day health centers. Yeah, these are fantastic. Of Great. Feel free to upvote other people's suggestions too. Connecting with faith community. That's fantastic. In our work on loneliness and isolation at the end of life, we actually found that people's ability to participate in religious activities was maintained up until the last months of life. So it can be a really profound way to maintain meaning for people. Group medical visits. Great. Calling family and linking them into hospital visits for older adults, group empowerment classes, age self-care. That's wonderful. I need to hear more about that. Referrals to community-based groups, villages, Little Brothers, Friends of the Elderly. Yeah, those are fantastic groups. Encouraging doing for others. Yeah, a lot of what we see is that many older adults, they don't want to be viewed as victims. Reciprocity in relationships is incredibly important here. And so any ways that we can encourage volunteer work or give people opportunities to give back can be really helpful. The Institute on Aging Friendship Line allows for that. The VA Compassionate Contact Corps does that. So there are some opportunities there. Okay, wonderful. Thank you for sharing. So yeah, there are a lot of interventions that are out there. And I think it's important that we continue to brainstorm as a group to make sure that we're really leveraging the local community resources that where people are doing really fantastic work. So social prescribing is this idea of connecting individuals to social service programs by using links and establishing referral networks between health providers and community-based services. So one example of that was with the Curry Senior Center and a new peer outreach program, which connected older adults with complex medical and social needs with peers who are of similar backgrounds and age. And we actually followed this program for about 2 years and found that it reduced loneliness, depression, and reduced barriers to socializing, as you can see on the right-hand side here. Here's one quote from one participant who said, it's just like having a friendship. A lot of folks I don't really want to be friends with. It's nice to have someone who you can talk to, who doesn't look down on you, who doesn't find fault in anything you say, and just looks at you as a person. There's telephone support has become increasingly common during the pandemic. The Institute on Aging Friendship Line, the VA Compassionate Contact Corps, which is accepting referrals. And a recent JAMA Psychiatry paper found that these can be quite impactful in reducing loneliness and depression. 2 other programs worth mentioning, which are national programs, for the COVIA Social Call Program and AARP Connect to Effect, which actually brings together a number of local interventions for people, no matter where they are in the nation. There's a number of direct interventions that can be administered in the nursing home, things like involving family members, which was suggested by some audience members, chaplain referrals for dignity therapy, age-appropriate technology. There's art therapy. There's an unloneliness project that's done down in Southern California, which has been really effective. So there's a number of different things that can be done. All right, so second is indirect interventions. Sometimes addressing loneliness is as simple as providing a hearing aid or clearing out a cerumen impaction, or providing a walker for someone who just needs help getting to a social activity. And then lastly, we really need to think about downstream consequences here for loneliness and isolation. Social isolation may lead to physical inactivity. People may have a harder time with post-hospitalization needs. They may not have a designated power of attorney. For loneliness, individuals may experience more pain, physical and psychological manifestations of loneliness over years of experiencing deficiencies in social needs. And so, myself and Dr. Diane Meyer from Mount Sinai recently wrote an editorial that is hot off the press. Alex will be mad at me because I haven't tweeted this out yet. But where we really try to think about this as an opportunity to shift our paradigm in addressing physical and psychological symptoms from just addressing the clinical or kind of physiologic things that we're seeing, and really shift to also addressing people's social needs. I think that has a lot of potential for potentially preventing some of these symptoms, or at least alleviating some of the distress that these symptoms cause. Okay, and then lastly, we should think about policy changes. Loneliness and isolation are hugely impactful on people's quality of life. And so we need to think about how can we shift some of what we're spending on medical care towards social care. How can we change some of our billing structures so that we can adequately compensate people, clinicians, for addressing what are really time-consuming, complex needs. All right, so if we go back to our clinical cases, for Margaret, who was having trouble volunteering, we actually connected her with an adult day health center, and we connected her with the Institute on Aging Friendship Line so she could actually call other older adults and give back. For John, who had a hip fracture, we tried to address some of his symptoms, his pain, work with physical therapy, and we also provided transportation to a local adult day health center so he could continue to socialize. And then for Bill, who loved his cat Yip Yip, we were able to work with the case manager to help him with transportation to get to his appointments. And we started doing advanced care planning very early on so that we weren't having to make medical decisions under duress. All right, so in summary, today we defined loneliness and isolation. We examined how older adults experience loneliness and isolation in the context of serious illness and the pandemic. And we applied a general framework for interventions to address social needs as we wait for the evidence to catch up. And with that, I'd like to thank you all. I'm incredibly grateful to everyone listed here, including Alex, who's been my primary mentor and provided such guidance. Carla Prosinoto, who's just a giant in this field and just so generous with her time, mentorship, and friendship. I'd like to go through everyone on this slide in so much detail, but I'll just, and I've definitely missed a ton of people, but I'm so grateful to for this opportunity and to the division for all of their support and moving this work forward. So thank you again.
Ashwin, that was fantastic. Congratulations. That was really terrific and so important for the times that we live in. And I have a number of questions that have popped up here, so I will ask them here. The first one was, what is the relation, this is from John Newman, what is the relationship between loneliness and purpose? I've seen purpose studied in the literature recently in similar contexts.
Yeah, that's a great question. Purpose, I think a lot about different dimensions of loneliness. And one that we often think about in palliative care is existential loneliness, or kind of, your loss of sense of identity or your place in the world, belongingness in your community. And so I think a lot about that with that's likely related to purpose. And so that's why a lot of times some of the interventions to address loneliness are about changing your perception of your social situation. Chaplains will often do, meaning-making interventions, dignity therapy, all of these focused on improving people's sense of purpose. So I think it's really important, and I think an opportunity to really address people's quality of life.
Terrific. There's also a number of questions about robotic dogs and cats. Are they the future treatment? Are we going to be prescribing those, or how do you get one of those?
Oh my gosh, robotic cats and dogs are actually pretty huge right now. So I don't know if people saw this, but there's a New Yorker article about robot pets. So in New York, the Department of Aging or Social Services, one of the departments, just started mass distributing robot cats because they're relatively cheap. And they figured, might as well try. It's the pandemic and people need companionship. And a lot of people respond really well to it. They recognize that it's a robot, but it still makes them feel better. And I think that also speaks to the fact that, sometimes you don't have to do a whole lot to help people feel better. And sometimes it might be multiple things that we do. You provide the robot dog, but you also, connect them with a telephone line. And so, multi-component strategies make a big difference.
That makes sense. And we have a question from Ann Pabini. Chronic serious mental illness is an enormous barrier to overcoming social isolation that causes further suffering. Is there any research that looks at loneliness and social isolation in people with a history of serious mental illness?
Yeah, that's a great question. I think there's increasing work there. In veteran populations who have PTSD or often may have histories of serious mental illness, there's specific groups that have been trying to work on that. What I found, just on my recent read of the literature, is that peer interventions actually make a huge difference for people with complex kind of intersecting medical and social needs. In our study on peer interventions, many of the individuals had histories of mental illness, histories of homelessness. Many, had histories of past trauma, and having peers who were, also transgender or also, had previous histories of homelessness or interactions with the behavioral health system in San Francisco. Having those individuals who are kind of outside of the medical system and could really approach people in a non-judgmental way as a peer was super effective. So I think there's a lot of ways, it's a highly intense intervention. And so I don't think it's right for everybody, but I think for people with high needs, we really need to explore those types of options. The VA is an amazing leader in that space.
Great. And here's a couple of questions from Alex Smith. He says, in the absence of clear, proven, effective treatments, should clinicians screen for loneliness or social isolation?
Yeah, great question. I think this comes up a lot, and I think it's a valid concern. For screening, it's important to have interventions and to be able to do something about it. Having said that, I think that this is different for a couple of reasons. The first is when I ask about loneliness, I sometimes think about that as an intervention in and of itself. I'd love to do research and actually figure out if it's an intervention, but people really appreciate having space to talk about this. Sometimes they'll bring up things like, grief from the loss of a spouse, from changing living situations, from a new medical illness. And, it really provides an opportunity to help people process those complex emotions and provide support, as an initial step to making referrals to others who might make a difference. And then the second is, I think that the evidence base is catching up. I don't think we should wait now for the evidence base to catch up because it just causes so much suffering now. But the pandemic has really highlighted some great interventions, and I think we need to do a better job partnering with these community groups.
Terrific. I also was struck by the fact that cognitive impairment was high, it's definitely a risk factor for loneliness and social isolation. And just thinking about how does severity of illness affect that? And what about their caregivers or their family members?
Yeah, great question. Yeah, we often don't ask people with cognitive impairment if they feel lonely because we assume that, they can't answer those questions. But I think people who experience cognitive impairment, it's an incredibly isolating condition. People feel a lot of stigma and shame around having that diagnosis. They feel uncomfortable in group activities. They may lose their ability to, participate in social activities that they've, enjoyed for much of their life. So I think we really need to explore this. And it is very much a shared social experience for people with cognitive impairment and caregivers or family members. We're currently doing work, Krista Harrison and I are looking at qualitative interviews of patients with dementia and their caregivers. And, some of the data that we're getting out of these interviews is just really profound and suggests that, we can do a much better job supporting people's social needs there.
Terrific. And I'll end with one more provocative question from Alex. Talking about controversial prolonged grief disorders now in the DSM. Some say this is pathologically, how to say it, making grief more sounding like it's pathologic. Do you have concerns about the potential that it's going to make loneliness pathologic?
Yeah, great question. I think you're right. I don't think we want to over pathologize loneliness. I mean, as we saw from the first couple of slides, people are singing about loneliness. There's tons of media attention about loneliness. This is a super common human experience. I think the problem arises when people are lonely, but they have trouble getting out of that state where it becomes really persistent or chronic. I think that's where we start seeing the health effects, and where we start seeing really profound emotional distress, which can be a burden for people from day to day. So I think, we don't want to over pathologize it. Some people don't even want to talk about it with their clinicians, and that is okay. But I think when people want to, when people are reaching out to get help addressing that, we need to have, ways as clinicians to support them and really prioritize their needs.
Terrific. Well, I think that's a good place to end. So thank you so much. That was just really terrific.
Thanks, everyone.
Take care.